Hello, I want to welcome you again to your course, Fundamental Topics for Sedation Dentistry. I am Alan Schwartz, DDS CRNA, and today we're going to be talking with you in this lecture about 16 of the toughest patients that you could potentially work on in your dental practice, in your sedation practice. So let's look at those potentially 16 tough patients. Then they are the severely obese patient, severe obesity. This used to be called morbid obesity, and the nursing profession has now changed the name to severe obesity. The patient with obstructive sleep apnea, the patient with gastro-esophageal reflux disease, the patient with hypertension, the asthmatic patient, the patient with chronic obstructive pulmonary disease, which, as you can see by the diagram, is a triad of diseases that all form into COPD. The diabetic patient, the patient with numerous allergies that's allergic to everything, the geriatric patient, and the pediatric patient, two different types of human beings. The ASA patient that has a physical status greater than or equal to 3. ASA is the American Society of Anesthesiologists, and we rate patients according to their difficulty of performing anesthesia based on their medical history and what disease processes that they've got going on that physiologically affect them. The chronic pain patient, the drug and alcohol abuser, the cardiac patient, the renal patient, person that's on chronic steroids, that's taking chronic steroids, and they can present quite an array of problems with us, and they don't have to necessarily be anabolic steroids, but somebody that's taking it for an autoimmune disease or something on this order to help the inflammation be reduced. And one of the things that I have now told you is that we have 16 tough patients, but I have lied to you. The reason that I've lied to you is that there really are 17 tough patients, and that is the patient that does not tell us the truth. We ask them questions like, have you had anything to eat or drink? And when we've gone in and looked at these patients, we see that they've got food, or we know that they haven't told us the truth, even if we're doing a dental sedation, because they'll get sick to their stomach and they might throw up gastric contents. We ask them if they're allergic to anything, and it turns out they'll say no, but they're allergic to things like milk or fish or eggs or wheat or soy or shellfish or tree nuts. And it's really hard because a lot of our meds are based on using these to help dissolve the medication and get it into a form that we can give intravenous to the patient. We ask the patient if they're allergic to any medications, and they say, no, I'm not taking anything. And you see that they've got just a pile of medications that we see stacked up on the table here or laying flat on the table. They just don't tell us the truth. And what we want to do is just have the environment and the experience be safe for the patient. So they've got to tell us the truth. We've got to make a safe environment, and sometimes you have to use your own intuition to see whether the patient is telling you the truth or not. One of the ways that we capture this is with the day of surgery assessment form. We have talked about this in a number of recent lectures, but part of this form is the part that the patient has to initial, and I put that in the rectangle that's in red here. we have the patient initial that they tell us that they haven't had anything to eat or drink for at least 6 hours prior to their dental treatment, that they've not smoked, vaped, or ingested or injected any illicit substances prior to their visit with us today, that they've made arrangements for someone to drive them home after their dental appointment for their sedation and their dental treatment, and that a responsible adult will be with them for at least the next 24 hours after dental surgery. So that's the day of surgery assessment form. We see that there are guidelines that we follow. They're not laws, they're not hard rules, but we all follow them. Anybody that's giving anesthesia to a patient, they are guidelines. And it turns out that the ones that you really have to adhere to and to make sure that you document that you followed are that clear liquids, so liquids you can see light through, is at least a 2-hour fasting period. For a light meal, it's 6 hours, and this consists of something like dry toast, maybe a hard-boiled egg, something that doesn't have any fat in it. And a heavy meal is at least 8 hours. So if the patient has had something that's fat or a big meal, we go at least 8 hours for that to move out of the stomach and way down into the intestines so that they don't have any chance of throwing it up and having an aspiration event. So I just want you to see that the forms that I use in my practice are available free for you and for you to adapt to your practice at sedationconsult.com. You'll see the forms and all the forms that you can download there. So let's talk about these 16 tough patients. Let's talk about the severely obese patient. You're going to find this patient, the presentation of this patient is very similar with what you're going to see with the patient that is having obstructive sleep apnea. So with the severely obese patient, they're going to drop their oxygen saturation very quickly because they have a reduced end tidal CO2. They're going to have a severely restricted functional residual capacity. Functional residual capacity is the extra air or oxygen in what's almost like a scuba tank within their lungs. And patients that are severely obese push up on their diaphragms and severely squish their lungs, reducing their volume so that they don't have that extra capacity of oxygen, so that if we lose the airway, they're going to go ahead and desaturate very, very quickly. So just remember that they're going to drop their oxygen saturation very quickly. They usually have high blood pressure, which is the force of blood trying to get blood to every cell in the body, all that fat, every cell, all the way from their big toe up to their top of their head. So the heart has to work overtime to get that oxygenated blood to every one of their cells. They have a big risk for sleep apnea, and there's a risk for aspiration from their stomach to their lungs. And they also have a risk for difficult airway management. We know that we're going to have a tough time, and sometimes we have to have extra people there, and we have to really titrate their drugs to make sure that we stay within the boundaries of our permit, but to make sure that they don't both aspirate and lose their airway. Asthma in obese pediatric patients is more common. So we have the chart of ideal body weight, but a lot of patients nowadays, and you know that it's been called an epidemic, are overweight. So ideally, we should be basing drugs when we dose them based on their ideal body weight. And when I'm giving a drug to a patient, it's not on their body weight that they're presenting to me, but pretty close to and at their ideal body weight. The way to calculate ideal body weight for males is to take and have 105 pounds and then add 6 pounds for every inch over 5 feet. For women, ideal body weight is 100 pounds and then 5 pounds for every inch over 5 feet. But we know that patients are quite obese nowadays. So you want to titrate their medications. You've seen this in many of the other classes with this course that you're taking, many of the topics. And it's just important to get a feel and to go gentle and to not be a cowboy when you're titrating these drugs. Give it to them, give it time to react, see how they react to the medication that you've given. And if you have to add, you get the feel and the touch for adding a little bit more to it, but don't go overboard. Let's talk now about the obstructive sleep apnea patient. And you can see that, as we've said earlier, this is related to the severely obese patient. But I've had patients that are even low on their ideal body weight. They're skinny patients that obstruct and have OSA, or obstructive sleep apnea. So let's talk about them now. Again, they're quick to drop their oxygen saturation, their saturation pulsatile of oxygen. The patient will tell you they sleep with a CPAP mask, and you ask them whether they're compliant with it. Do you use it every night, or is it an adornment on their bedstand? I'd just like to show you therapies that are available now. As the body falls off to sleep, the muscles, especially the skeletal muscles, will paralyze when they are in REM. And there is a therapy now that monitors their musculature, and it's called Inspire therapy. So it has to be done under sedation. It's put in by a sleep physiologist. It could be an ENT surgeon, ear, nose, and throat. There are people that are trained in inserting this therapy. So what it uses is it's monitoring the chest. It has a generator that is similar in battery to a pacemaker, and it applies a light electrical signal to cause tension or muscular tension to keep the person breathing so that their tongue doesn't fall back into the back of their throat and their muscles in their throat have some kind of tone so that they don't obstruct. And this is sensed by their breathing. It will sense obstruction, the Inspire therapy. So they are quick to, again, obstruct their airway, and the biggest obstructor is going to be the relaxed tongue and then the musculature of the throat, the soft palate, the esophagus, and it will just form a ball valve and prevent any air moving in and out from their lungs. So as a result of prolonged airway obstruction over years and years and the drop in their saturation, their oxygen saturation, they'll have a risk for bad heart rhythms. And you'll start to see rhythms such as these that will occur and could lead to some severe heart rhythms in that patient. They're going to have, because they're constantly being woken up by their body, by their brain, daytime sleepiness because there's not enough REM sleep. So you'll see them tired. They usually have high blood pressure, just like the severely obese patient. And they have, again, a risk for aspiration from their stomach to their lungs of any gastric content. And they also have a risk, especially the fact that they're sleep apneic patients, for difficult airway management. We use a score, and it's called the stop bang score. We use that in anesthesia, and we provide that number, and we chart that in our anesthesia chart. And I want to go through that with you now. So it's, again, called the stop bang score. So we find out if the patient is snoring, tired, somebody has observed them having sleep apnea or having periods of apnea. The P is for blood pressure, which is hypertension. Their BMI, their body mass index, is over 35. Their age is greater than 50 years old. Their neck circumference is greater than 40 centimeters, so you'll have to measure that. And then their gender is male. So you can see a stopping score of 8 is going to be a really good chance of that patient obstructing. So things that we do to help these patients is to position them properly. And we talk about the sniffing position. You'll see that this patient who is severely obese because of their body habitus is ramped up with blankets and a pillow behind their neck to get them into the sniffing position, which is the ideal position for breathing. That is the position where if I were to put a really good smelling pie in front of your nose and you were to go and sniff it, you would lean forward your neck to be able to really get some good breaths. So that just aligns the different axes in our airway because we have such sharp axes and gets them into that sniffing position so that they're able to breathe properly. So when they're in the dental chair, we want to make sure that they are in that position. And we do that with blankets and pillows. Be liberal with oxygen. I have the patient pre-oxygenate, especially if I know that it's an OSA patient and an obese patient. And that means I have them take slow, deep breaths before we start. So I want to load up their FRC with oxygen. And we want to keep them oxygenated the whole time. Oxygen is our friend. So I want you to take some slow, deep breaths through your nose or through your mouth if you're using a mask, and really fill up your lungs. Big, slow, deep breaths, and let them do that for a couple of minutes. And here we are doing that with a nasal hood that we're going to give nitrous oxide to the patient with. And then again, it goes without saying, titrate the meds that the patient's going to get. Don't go overboard. Let them reach a happy place for both them and you, and to keep their breathing going. Let's talk about the patient with gastro-esophageal reflux disease, also called GERD. With these patients, even without anesthesia, they can aspirate. And there's people that chronically aspirate that leads to some pretty severe, potentially cancerous gastrointestinal diseases. So aspiration is when acidic stomach contents involuntarily go into the lung tissue. And there is a syndrome, and the patient would more than likely die because of the pH in their stomach from the hydrochloric acid there. If they aspirate more than 25 milliliters of a pH less than 2.5, there's a pretty good chance that they're going to die from that. So aspiration, making sure they're NPO, making sure they're in the sniffing position, making sure that you titrate their meds is so awfully important so that they don't aspirate. In the operating room, I just like to show you, we apply cricoid pressure until we can get an airway with an endotracheal tube. It's also called Selleck's maneuver. And what we do is we push down on the cricoid cartilage while the patient's very asleep before we intubate them to crush, if you will, their esophagus against their cervical spinal column, so that they don't have any chance of aspirating. I like you to also see what I saw from some courses that I took from being able to get privileges at a hospital, that anesthetic medications are possible causes for aspiration of gastric contents. And if you look further down the list, you'll see that patient positioning in a non-compliant patient and outpatient surgery, which counts as dental, are also reasons that patients can aspirate gastric contents. So anesthetically, I want you to consider that NPO status and documentation of it is crucial. And then again, here's that list. Memorize it, know it, and follow it. It's not a law, it's not written into your dental rules, but it's something that we all follow in anesthesia. There's some things that you can give the patient to help reduce acid if you're really worried about them aspirating. And one of those is the histamine blocker, the H2 blocker in the gastric chance or place where histamine can be made is the blocker is famotidine or Pepcid. There's also a gastric motility drug called metoclopramide that will make their stomach gurgle and make their intestines gurgle and really move food and any gastric contents or acid down the line. We can also give the patient 30 milliliters of Bicitra, and for our pregnant patients that have a lot of stomach acid, we give them Bicitra to drink, which is citric acid, which makes absolutely no sense on why it works to neutralize acid in their stomach, but believe me, it works. So we give that to a patient. I have tried drinking it and it does not taste well. So again, titrate their meds and just take really good care with the patient. Let's talk now about hypertension. This is a picture showing you what normal blood pressures are. I don't ever ask questions on any exams for that, no numbers, but I think that you should know them and know that these were all adjusted back in 2017. There has been no updates since then by both the American College of Cardiology and the American Heart Association. So for an adult patient, 120/80 or less is normal blood pressure. Now your patient that's coming into the office for a dental appointment is probably going to have elevated blood pressure, especially since they're requiring sedation because of the anxiety that they're feeling. But if a patient is relaxed and calm and they've got blood pressures that are either stage 1 or stage 2 hypertension, these can severely hurt their organs by the pounding of the heart and the amount of work that the heart has to do to get those blood pressures way up in the air. So delicate organs can be hurt. We've got blood pressure that's just pounding against these delicate organs, and it's going to damage them over time as well as weaken the heart. So atherosclerosis also causes hypertension because the body is set to deliver oxygenated blood to every cell in the body at every moment. We see that cardiomyopathy can occur. If you look at the heart on the left, you see that the left ventricle is quite heavy muscled, meaning that that is where the 120/80 occurs. The heart picture on the right is an enlarged heart because of it having to pump so hard in a hypertensive patient. And eventually, over time, that heart muscle will just weaken and they'll have congestive heart failure. The heart muscle, if you will, just poops out. It becomes flabby and soggy. If the person has hypertension, it can pump so hard against the blood vessels in their brain that it can cause a stroke and just really blow that blood vessel out. So anesthetically, we want to consider what med the patient is taking. This is where you would get a sedation consult from their physician to see what they should take and what they shouldn't take. If they're on losartan, which is an antihypertensive medication that none of your sympathomimetics and any of your vasoactive meds in your drug toolbox will not work if a person's on losartan. So you're going to need to talk to your patient's physician about that to see what they should and shouldn't take to control their blood pressure medications. Even if the patient is NPO, they should still remain on their antihypertensive medication. They should not get off of them. And patients make that mistake quite often, and it's dangerous for those patients. So remember that we want to keep the patient normotensive, in that state of homeostasis during their anesthetic visit. This is where they live normally, and we want to keep them there during their dental sedation. So we want that homeostasis. And we want to then minimize the amount of pain and anxiety that the patient is feeling. Let's talk now about the asthmatic patient. You're going to see again a risk for rapid drop in their oxygen saturation, their saturation pulsatile of oxygen. And anxiety can trigger asthma, especially in children. It can really constrict their airways, their small airways, as they branch down into the terminal bronchioles of their lungs. Exercise can trigger asthma. There's exercise-induced asthma. So for the patient that is feeling that, it's extremely stressful for them because it comes on quickly and they're not able to move air. They're air hungry, and it's extremely stressful and hard for them, and they can desaturate very quickly. So we need to apply quick action for them. Before I even start the case, I would have the patient use their inhaler and bring it to their appointment with them and have them use it before you even go back into the operatory, or if you have them use it properly in the operatory. And by properly, what I mean is that they need to breathe out, do a couple of puffs with the air out of their lungs, take a couple of puffs with their mouth closed around it, do not talk, and take a big deep breath in and hold that breath as long as you can. And then when they're ready to breathe it out, we can breathe it out, do another 2 puffs. So breathe out, puff, puff with their inhaler, big deep breath in, hold it. Hold it there as long as you can, and make sure you document that you gave the patient or they gave themselves 4 puffs, but have their inhaler at hand while you're in the operatory. And you should have your own inhaler that's not expired in your drug toolbox. If you look at the movie, you'll see how to properly administer albuterol. And then I've got a written description for that for you here. Let's talk about the patient with chronic obstructive pulmonary disease, also called COPD, which is going to be another breathing anomaly. And as I said in our introduction, it consists of a triad of diseases. And those diseases are emphysema, and I'm going to show you what that is in just a second, chronic bronchitis, and then asthma. If you look at the alveoli and the picture on the right, away from the 3 circles, you can see that the picture on the top is alveoli that have had their septa in between the alveoli, which gives it so much surface area. They've been diseased and eroded, and they're gone forever. So they've been destroyed. And so now you've got these enlarged air sacs instead of the picture below, which is just hundreds of millions of tiny little balloons, if you will, that are normal, healthy alveoli air sacs that have blood vessels intimately associated with them to exchange carbon dioxide and to pick up oxygen. So before we start, somewhere when you're doing your day of pre-op assessment, listen to the patient's lungs for any symptoms of difficult breathing, wheezing, gurgling, any sounds that their lungs are making. And then what we do when you hear that, and we're going to especially hear that during the winter months, is have the patient cough and deep breathe. So if you have them take a big deep breath in and then cough as hard as they can, have them do this a number of times. I'd have them do it 2 or 3 times. So big deep breath in and then a gut-wrenching cough. It will open those alveoli. When the alveoli close, it's called atelectasis, and we want them to cough and open up those alveoli, and then re-listen again and then document that they have opened up and they don't have the wheezing, the gurgling, any of those sounds that we don't want to hear. We want to hear air exchanging in and out of their lungs. So get a good stethoscope and listen to them breathe preoperatively and document it, as I said, on that day of preoperative assessment. If they're a smoker, they have to go at least 8 weeks or longer for their lungs to clear out. So there's going to be a lot of sounds that they're going to hear, and they may have prolonged coughing as the lungs rid themselves of the toxins that are in the carbon particles that are in their lungs. So make sure that you document that they have done pre-procedure coughing and deep breathing as we demonstrated before. Let's talk now about the diabetic patient. These are patients that are going to be at a risk for infection. And the reason is that if they don't have good glucose control and there's molecules of glucose circulating throughout their extremities, they're going to get lodged and block down into the small capillaries. And they have a degree of wound healing that will be delayed because of this poor circulation, especially to those extremities. So there's going to be a risk not only to the extremities, but to major organs. And they're going to have autonomic nervous system dysfunction because of the circulating high glucose molecules. They're going to really lodge and plug up these small blood vessels, especially as they get down into the size of a capillary. So not only are they going to have circulatory problems, but they're going to have neurological dysfunction as the circulation is poor and poor in an uncontrolled or poorly controlled diabetic. So anesthesia-wise, what I want you to consider are that they're going to have a risk for cardiovascular instability, especially the pretty severely diabetic patient. They're going to have a weakened lower esophageal sphincter, and there's a really good chance for aspiration with these patients. So when you do their IV stick, make sure that you have an AccuCheck or some type of a glucose monitor in your drug kit so that you're able to document their blood sugar for the drop of blood from the needle that you've done for their IV stick. So I would measure that and document it. We were taught, and we still follow, that these should be your first of the day appointments. So we want to get them in early so that they can get back to their eating regimens, their insulin regimens, any of their meds that they take for the non-insulin dependent diabetic. So even if it means bumping a patient, we want to get them in early and the first day appointments. So be aware of what their regimen is, and we don't want to change that unless you have a physician from their day of pre-op assessment tell you when they should or shouldn't take their oral hypoglycemics or their insulin. Let's talk about the patient that is allergic to everything. So it's going to be important to get a thorough health history and to make sure that you document and that we have a copy of the patient's med list that they're allergic to and the med list that they're taking. So an allergic reaction, a true allergic reaction, can occur extremely quickly. So discontinue the causative agent as quickly as possible. And then we've got to get into some action to counteract the allergic response. We're going to have to manage their airway and make sure they're exchanging, even if it means using an oral airway or getting into some of the advanced airways. Make sure that they're exchanging oxygen. That's going to be one of the first things that we do for a patient that's having histamine pouring out and then causing this swelling of their airway, their tongue, their lips. They're going to have an extremely rapid drop in blood pressure. So we're going to want to open up their fluids, have another bag ready, and we're going to talk about a regimen that we follow. The first drug we would give for severe allergic reaction is going to be epinephrine to get the heart rate and the blood pressure up. Then we're going to apply and administer intravenous steroids, an antihistamine for their system, for circulating cells in their bloodstream, the basophils and the mast cells that are pouring H1 histamine into their blood vessels and circulating through their body. The gut is also going to pour out a lot of histamine. So we've got blockers for that and the H1. So the H2 are the gut histamine cells. So the H2 blocker would be famotidine or Pepcid, and the H1 blocker is diphenhydramine, also known as Benadryl. And we're going to want to apply their epinephrine inhaler if they've got that. So your albuterol is going to work really well. And if I were you, I would go over to the store and you can buy over-the-counter Primatene Mist, which is going to be your racemic epinephrine inhaler. So add that to your list, Primatene Mist. They're not real cheap. They're about $60 the last I heard, but that is going to help with your patient that has an allergic response, as well as their albuterol inhaler. Let's talk now about the geriatric patient. As I said, they're going to be quite different from the adult patient and the pediatric patient. A lot of different considerations. One of the considerations is because of atherosclerosis, the amount of drug we give a patient for their sedation, because of the decrease in their cerebral blood flow, especially as they get older, their need for anesthesia is going to really drop. So we're going to want to titrate their meds. They're going to use a lot lower dose than a younger patient, a teenager or a young adult or somebody in middle age. So they have a lower anesthetic need. Their blood vessels, because of atherosclerosis, are like lead pipes, so their flows just are not as much throughout their body. And we want to make sure that we then maintain where their homeostatic blood pressure is, because we want to make sure that we have circulation going to the brain. And if you've got the patient that you're working on, make sure with pretty much all your patients that you elevate their head slightly and make sure that they're in that sniffing position. They're going to also have decreased ventilation under anesthesia, and you may have to remind them to take deep, big breaths of oxygen every now and then to make sure that as they're desaturating, we open up those lung tissues again. So positioning is going to be very important. As I said, I like the head up a little bit, and I like them in that sniffing position. They are going to have increased body fat to muscle. It's called the fat to muscle ratio. So we're going to want to make sure that we keep them warm or at normal temperatures and that they're positioned properly. Because of the fat, they might be up against a hard surface with the arm board or the armrest of the dental chair, and it could cause a breakdown of their skin. So we want to make sure that we position them properly. And they have a decreased hepatic blood flow as they increase in years. And remember, we talked earlier that that's where our drugs are going to be metabolized. So they're not going to get rid of their drugs quickly at all that we've given them IV or PO. And they have decreased laryngeal and pharyngeal reflexes to protect their airways. Let's then talk about and contrast the pediatric patient, see how they're different from the geriatric patient, and even just the adult patient. So let's look at child monitoring versus adult monitoring. I want us to look at the differences in their airway, their cardiovascular system, their pulmonary system, and the differences in their ability to maintain temperature. So for the child, they have a relatively much larger tongue in their small mouth, and they have an extremely narrow airway. This is a patient that's being intubated, a pediatric patient, and you can see that the red arrow is pointing to a little black hole just below their epiglottis, and that is it. If that gets swollen or blocked, the patient does not have a patent airway. So we've got to treat it with a lot of respect compared to the adult airway, which isn't much better, but it's much larger, as you can see with the adult tongue, and the fact that their mouth and the floor of their mouth and their throat is much bigger, and the skull is bigger. They also, besides having a narrow airway, have a much larger head in relation to the amount of body they've got, especially if the patient is much younger. So if you're treating pediatric patients, we've got to consider those things in relation to their airway. Cardiovascular-wise, their system has a faster heart rate, especially the younger the patient, which means they're metabolizing drug quickly and they have increased oxygen needs. So with these patients, the younger they are, we're going to have a lot more water there. So our water-soluble drugs, especially Versed, are going to be distributed and metabolized very quickly. So we may have to redose that. Pulmonary wise, if any of you have had secretions, we're going to notice that with them, that the younger they are, they're going to have secretions increased, they have narrow airway passages, and they have a small FRC. So for a child versus an adult patient, we consider a child that is usually age 8 or greater is considered an adult. So if there's any breast development or if there's any armpit hair that's developing, that's considered then an adult, and it's usually after or older than age 8. And temperature wise, the younger the patient, we want to keep them warm because they're going to lose a lot of temperature, a lot of heat through their head. Let's look at the American Society of Anesthesiologists physical status patient that's at least 3 or greater. So these are going to be patients with disease processes that are sick, that can really confound and complicate an anesthetic. Some states, their rules will not allow you to even practice with a patient that's 3 or greater. So give them a fair assessment. Don't make a patient that's 3 or 2, or you're going to get into some trouble if you have any problems with that patient. So make sure you follow their guidelines and give them a fair ASA physical status assessment. So let's look at what makes a patient ASA 1, and we have them through 6s. An ASA 1 patient, physical status 1, is a normal, healthy patient. They're not taking any medications for their heart, their lungs, their blood pressure, any diabetes, any thyroid conditions. It's just a normal, healthy patient. An ASA 2 patient is a patient with mild systemic disease. So they could have blood pressure problems, thyroid problems, It could be somebody with mild heart disease that is taking a med to get them back to being a, quote, normal, healthy patient, which is an ASA1 patient. So their disease processes can be corrected with taking a med of some kind or some kind of treatment to get them back to a healthy state. An ASA3 patient is going to have severe systemic disease. This is somebody with severe COPD, somebody with severe asthma, severe hypertension, severe cardiovascular disease. There's so many different disease processes that they're taking meds for. They may be on chronic oxygen and they have to stay on those meds. An ASA4 patient, physical status 4, their severe disease is a constant threat to their life. 5, they are so sick that they're not expected to live unless they go into surgery. So you can see that these patients, as these numbers increase, get really tough to take care of anesthesia-wise. 6 is a patient that's been declared brain dead that they're going to be harvesting organs for. And I like to let you know about the E status. So this could be a 1E, a 2E, a 3E, a 4E, whichever. So this is a patient that is in the health status that we just outlined, 1 through 5. And if they come in, if they've been in a severe car accident or they've had a severe fall or something that's taken them into an emergency state that's going to potentially lose their life or limb, it's going to change the anesthetic course greatly. So we could have a normal, healthy football player with just a good cardiovascular and lung system that is been in a severe accident that makes them a 1E. So I like you to know of that. So if you have a permit that is a deep sedation or general anesthesia patient or greater, your dental rules should allow you to practice. So if you're not a physician, I would get a physician consultation release. And again, that form is available on our website. You would fill out, as a dentist, the top portion and tell the dentist the physician, what meds they're taking and what your concerns are medically speaking. And then let the doctor answer what antihypertensive they need to be on, what diabetic med they need to be on preoperatively, so that you can go ahead and do their sedation and that they're released for you to be able to treat them in the office. But if you're not a physician, you need to find out if they should stay on their anticoagulant, any of the other meds that we talked about, like blood pressure and any pulmonary meds that they're taking. So get that in writing and have that back before you start the anesthetic on those patients. So you have to look at the disease process. What disease system is being affected? What part of their body system is being affected and can impact their anesthetic? So get that pre-procedure physician consultation and make sure that that patient is tuned up and ready to rock before you bring them into the office for their sedation and have potentially any really bad moments with them. Let's talk now about the chronic pain patient. This can bring a lot of stress to a practice. If they're using pain medications, as we talked about in previous topics that we covered in this course, the liver metabolizes these drugs and they're metabolized very fast. It's as if the liver is tuned up to see it and recognizes it very quickly and breaks it down very fast. It's got all of the chemical chains in order so that the drug can be eliminated. The drugs that we give patients are toxins, if you want to think of it that way. The body does not see it as a foodstuff. It's going to see it as a chemical that needs to be either going through the bile system and then into the feces or eliminated in the urine after it passes through the kidneys. So tolerance can develop for any of the doses of drugs that we use, narcotics, benzodiazepines, but the side effects still will multiply and be in those patients even if they're not getting the full effect of the narcotic or the benzodiazepine the way they're used to. So we can have reactions because of side effects of the drugs, such as respiratory depression, slowing the breathing. Any of those things can happen and is one of the major causes for drug overdoses and drug-related deaths. So you want to be careful with these chronic pain patients, say, that are taking narcotics, because naloxone or Narcan will very quickly reverse and occupy the opioid receptors on the cells, and the patient will have a rebound, tremendous amount of pain that can put them into a really bad place and potentially cause death. So I'm showing you here the benzodiazepine half-lives for a lot of the common benzodiazepines that we use in dentistry and that patients are taking prescribed from physicians. A half-life, remember, is the amount of drug that's in the bloodstream that is half the dose that the person takes. We want to measure how long it takes for there to be half that dose in an amount of time in the person's blood. And it takes 5 half-lives for a drug to be eliminated. So the drug is going to be metabolized fast. Be aware of using any antagonists because they can have a sharp rebound effect that could be something that could affect their life, especially with the narcotics. There's other things that we can use for the patient that will also provide pain management or an analgesia. And those are, other than opioids, they're non-steroidal anti-inflammatories, drugs like ketorolac, which is Toradol, and they've got IV Tylenol now. It's called Afirmev, and then there's IV ibuprofen. So you can use those along with narcotics or in place of narcotics, depending on the amount of pain that you anticipate the patient having intra-op, pre-op, post-op, so that they're going to be comfortable. If you've got a sedation permit that will allow you to use it, ketamine is also a wonderful sedative and it's partial pain relief, and Precedex to just really calm the patient. So we've got to be aware of, with the chronic pain patient, of sudden acute pain. And this can be brought on by using a reversal or having the dose that the patient took be metabolized and, if you will, wear off quickly. So here's a list of some of these symptoms. Some of them are life-threatening that a patient can have or experience if they're going through withdrawal. They're all pretty bad. Something like lethal dysrhythmias, cardiac dysrhythmias, there's diaphoresis or sweating, they could be crying, agitation, anxious. A lot of things like tremors and seizures can occur. Pulmonary edema can occur. So we've got some really bad things, and we just don't want a patient that's taking chronic anything in the way of narcotics or benzodiazepines to go through any of these things. So we want to make sure that they're off their meds and that they haven't self-dosed themselves with some of these chronic meds that they're taking, especially, like I said, the benzodiazepines and the narcotics. Let's talk about the drug and alcohol abuser, since we were just talking about that now with the chronic pain patient just before. Patients, as we know, don't tell the truth, something we talked about at the beginning of this seminar. So we want to make it a safe environment for them so that they can tell us what we need to know so that they will get through their procedure well. If you're in a population that you're treating, that you're worried about any drugs that they may have, there are urine drug screens. And if you look at some of the labels up there, you can see morphine, tetrahydrocannabinol, which is marijuana, amphetamine, cocaine, benzodiazepines. But this list shows you the different types of urine drug tests that you could have available for that patient population if you're treating someone and you're worried about it. And we said this before in one of your other topics, but the absolute, if you will, thing that I will not do an anesthetic for is a patient that tests positive for cocaine. They can have coronary artery vasoconstriction and it causes tachycardia. So the heart may not be receiving enough oxygen through the coronary arteries. And especially the stress that occurs with dental procedures, we have to worry about that. So don't be shy to cancel a case. I know it's hard to do, but it's going to be harder to put up with a bad situation or something that causes the patient a lot of harm or death. So they have to know the rules totally at the pre-op visit so that they know to not use those things. We're even told that if a patient has something like a breath mint, cough drop, something on that order, it stimulates gastric secretions. In some places will cancel the case and postpone it to another time. And I can tell you it does not make anybody happy when that happens. And if they do take meds and don't tell us what's going on, that they've taken those, we can have something called a paradoxical reaction. And that is that a reaction will occur and we don't even know what it is, what it will be, and what caused it. They may have tachycardia, severe bradycardia, they may go flatline, they may have severe hypotension. There's so many different reactions that occur. It could work to cause an allergic reaction in conjunction with that med that's taken. And so we're just going to have a surprise package of some really bad reactions that the patient could have. And then there's a risk, as we said earlier, for cardiac dysrhythmias, hypotension, hypertension. It's just hard to say what's going to happen to the patient. And then there's that risk of death. Let's talk about the cardiac patient. A lot of us have been trained to be able to recognize and know what's going on with the cardiac patient. We're going to look at the meds they're taking. We're going to interview them in their health history and find out what they're being treated for and what their problem is with their heart. So we have to look at the type of the disease that they have, the disease process that's affecting their heart, and the severity of that disease. Is it a valvular problem? Is it atherosclerosis that's causing the problem in the coronary arteries? Is there a rhythm problem? Do they go into a lethal rhythm? Do they have an AICD that they're using, an automatic implantable cardiac defibrillator? That's going to really tell you a lot, and it can affect your treatment of that patient for sure. Or is it a heart muscle problem where they've got atherosclerosis, but they've also got cardiomyopathy in the way of left ventricular hypertrophy that we saw a picture of, or congestive heart failure. We have to look at the comorbidities that the patient has as a result of having this heart disease. Do they have hypertension? Is there a valve problem where there's leakage and they're not getting good circulation to the extremities, any to their brain? Is it an ischemia problem or is it a dysrhythmia? So we want to make sure we interview the patient. If you have to, I would get a physician consult. Use your physician form that we showed you earlier to get an opinion from their physician. And you have to, if you're using electrocautery, consider that they have a pacemaker or if they have an AICD that could be fired because of a result of electrocautery. It's important to assess also, with all we've talked about, their exercise tolerance. And one of the standard questions that we ask the patient is if they're able to walk up 2 flights of steps, if they're able to mow the lawn, anything that's going to require some exertion. You want to see what their tolerance is. If they say, I'm in a chair all day, it's going to tell you a lot different than the person that is walking long distances, but still may have some cardiac disease. You want to know what their peripheral vascular status is and the vascular status to their heart. Is there a problem going to the brain, any of the extremities, to the heart muscle itself? The heart commands a lot of oxygen and a lot of adenosine triphosphate, or ATP, to be able to fuel itself. Let's talk about the renal disease patient. This is something that we don't cover a lot, or that was covered a lot, for me at least, in dental school. So I want to go through that with you now. The kidneys are a major organ just like any of the others, the lungs, the liver, the brain, and they're going to command a lot of blood supply. Here's a picture of kidneys with renal disease. And these are patients that are in hypertension. You can see the kidney tissue over on the right side of the diagram is totally abnormal compared to what a normal healthy kidney looks like. So being that it's a major organ and that it commands a large blood supply like the other major organs, it's going to signal the body that it's not getting enough oxygenated blood, and the person's probably going to have hypertension, and then all the bad things that we talked about earlier with hypertension, like cardiomyopathy. You can see in the bottom of this diagram that that heart muscle is really enlarged, especially that muscular left ventricle. And look at the size of the ventricle itself. There's not a lot of blood being pumped out of that heart because it's so enlarged. So the kidneys could be affected as far as the tissue dying. And if we've got high blood pressure pumping into the brain, we could potentially create a stroke there. So they're going to have, more than likely, cardiovascular and hepatic disease. One of the things, since the kidneys regulate our electrolyte balance, is that they're going to have a lot of potential for potassium, high potassiums in their blood. So knowing that, we don't want to use any fluids that have any potassium in there. And the fluid that comes to mind that's a common dental fluid is LR, lactated ringers. It has potassium in it. So we're going to want to use normal saline with those patients. And the patients are going to have hematological changes. The kidneys are not creating or pouring out erythropoietin, which is going to stimulate the bone marrow to make red blood cells. So they're going to have low blood cell counts on account of the fact that their kidneys are diseased. The more disease, the less or none of the erythropoietin is there. So the patients are probably going to be anemic. They're going to be more susceptible to infections. They probably have diabetes on top of this too. That's going to complicate their blood sugars and all the other organs that we talked about earlier with the diabetes patient, the diabetic patient that has circulatory high glucose content and can have problems with that going through the blood vessels, getting those sugar molecules caught in the capillaries. So we're going to want to get a pre-op lab work for the patient and make sure that they're dialyzed and tuned up, ready to go before we have our visit with them. Be alert to their drug dosing and the renal clearance of those drugs. And again, avoid anything that's got potassium in it. Use normal saline. And we use a mini drip with these patients, meaning that the drip that you're using, they've got a mini drip that creates 60 drops per milliliter as opposed to 15 drops per milliliter for a standard drip. So we're going to want to really restrict the fluid that we give these patients because they're just not able to clear it because of their sick kidneys. So this picture shows you the drip chamber assemblies. You can see a mini drip that's going to have 60 drops per milliliter. And then you can read on the package, some macro drips are 10 to 15 drops per milliliter. Let's talk finally about the chronic steroid patients. Patient takes steroid, as we talked about, for a lot of autoimmune and immunological diseases, stuff like lupus, myasthenia gravis, multiple sclerosis, things like this. So we've got two parts to our adrenal glands. There's the medulla and there's the cortex. And they sit right on top of the kidneys bilaterally. And they have an intense blood supply. So the adrenal cortex, the steroids that we used are synthesized and they're called corticosteroids because of that reason. The adrenal medulla, we're going to see, produces a couple of very common or very prominent neurotransmitters and hormones that we have in our bloodstream. Here is a picture of some of the more than 30 steroid hormones that are synthesized in the adrenal cortex sitting on top of the kidneys. So we've got mineralocorticoids, glucocorticoids, our androgens. The big one for us is that catecholamines, that would be epinephrine and norepinephrine, that are synthesized in the medulla. And certain peptides are synthesized also in the medulla. The big thing are going to be the glucocorticoids, though. That's where cortisol and cortisone are synthesized. Notice again where epinephrine and norepinephrine are synthesized in the adrenal medulla. So cortisol is also called the stress hormone. Anytime we're experiencing stress, our adrenal cortex pours an amount of cortisol into the bloodstream so that we're able to withstand the stress. Those steroids are used for protein, carbohydrate, and lipid metabolism, and they mediate catecholamine-induced effects on the heart and the vasculature. And that's where the key is. That's where the cortisol is going to come in because of this mediation that it does, so that our body doesn't decompensate and potentially cause severe reactions or death if the person is exposed to stress. So they're central to our body's physical and mental stress that are created, that are pouring out norepinephrine and epinephrine. There's that mediation that occurs. If the person has inability to respond to that stress, it's called an adrenal crisis. And they can't respond, and one of the horrid things that can happen is it leads to death. So if the person is taking exogenous glucocorticoids, they may be getting that from their physician. It takes a long while for the adrenal cortex to catch up to get the proper dose of cortisol into the bloodstream. If they're taking 5 milligrams, let's say, of prednisone, and it's for greater than 2 weeks, it takes 12 months for the adrenal cortex to catch up and to be getting things so that they're able to respond to stress. So if they've been taking steroids, we're going to want to administer hydrocortisone, and this should be in your drug kit. Patients do not overdose from normal doses of any of the steroids, so don't hesitate to give it. One of the things that they're saying now, one of the new procedures that's coming out, is that, read in the recent literature, is that if they're no longer taking steroids and the procedure is relatively non-invasive and is not going to produce a lot of pain, there's no need for preoperative steroids. So it's going to be a judgment call with you, your studies, your judgment, and if you need to get your physician, the patient's physician, to help you make a decision whether to give the patient some exogenous steroids such as hydrocortisone, also called Cyucortev. So the final words are: be clued in to the meds the patient's taking. Get to know what they are, what they're doing, how it can affect your anesthetic. We've talked about a lot of these already, and we just want the patient to do well. And a good source to be able to look up these meds, it's an excellent book and it comes in paperback, is the Lexicomp's Anesthesiology and Critical Care Drug Handbook. Thank you very much.